Of course, it's a large topic to cover in 20 minutes, so I will only talk briefly about the two things that are most advanced. The DNA methylation has already been covered by Quinten, so I will quickly go over it, and then I will go into the microRNAs. DNA methylation, Quinten already explained the basics of it, but what is important here, I think, is the translation from what's going on in the liver onto a measurable marker in the blood of the patient. And as Quinten has showed you, that was a study done in a rather small cohort of patients, and the question here was indeed focused on the difference between those with minor or no fibrosis versus those with advanced fibrosis, and they looked at the methylation of promoter regions of interest, and one of the things they looked into was the PPAR gamma promoter region, and there was indeed clearly a link between the hypermethylation of some gene loci in that promoter region with the results of the liver tissue in terms of fibrosis. But that's, of course, interesting, as has been said in the liver biopsy, but does that translate into a blood-borne or blood measurable biomarker? So they ask themselves, indeed, the question, first of all, can we measure that in plasma, that hypermethylated PPAR gamma promoter region, and does it if we measure it in the plasma of the patients, in the cell-free DNA of human plasma, does it also there correlate with liver histology in terms of minor or no fibrosis versus advanced fibrosis? Again, a rather small cohort of patients, but it's an interesting proof of concept, and as Quinten already showed you, there is indeed, it's detectable in plasma, that's the first thing, and also with the plasma determination of that parameter, you can clearly see differences between the two categories of NAFLD patients, and even more if you compare it to control. So it's a proof of concept that indeed you can measure it, and the question is then, of course, how can we use it as a diagnostic? Here they made the comparison with the NAFLD fibrosis score, and in this small cohort of patients, to identify the patients with advanced fibrosis, it has an ROC of 0.9. Of course, in 25 patients is an interesting concept, but still needs validation, of course, but it's very promising, I think. What is also important is that it was not etiology specific. They tested it also in alcoholic liver disease. And then, of course, with that kind of biomarkers arises the question, what is the source of this? And then it becomes really interesting also from a mechanistic point of view. And they could very elegantly show that what they measure in plasma was really coming from the hepatocytes. It was not coming from myofibroblasts. It was not coming from PBMCs, but it came from the hepatocytes, probably dying hepatocytes. That is still something that we should look into. And if we then look at the mechanistics of PPAR gamma, then it becomes even more interesting, because we know that in hepatocytes there is quite a little PPAR gamma expression. PPAR gamma is far more expressed in stellate cells, but when stellate cells become activated, then the PPAR gamma expression goes down. So that's really an interesting crosstalk there, because this is really a signal coming from hepatocytes with PPAR gamma, influencing probably also the hepatic stellate cells. So interesting work, and we have to look very closely in that. Then the second part is about the non-coding RNAs, and according to the number of bases, there are split up in long and small coding RNAs, and then in the small non-coding RNAs, there's still different fractions to study, but we have the most knowledge now on the microRNAs, which have about 21 to 25 nucleotides. And how is their physiology? Because that's important to really understand what we can do with microRNAs as biomarkers. So, of course, they are synthesized in the nucleus by polymerase II as a primary microRNA, which is then further processed by the Drosha complex to a precursor microRNA. And that precursor microRNA then leaves the nucleus, where it's further processed by the dicer complex, and this is then the end results. It's a double-stranded microRNA, which is, let's say, the mature form of the microRNA. And that can then exert its function, and DNA methylation, as you have seen, is an epigenetic process influencing the transcription of the DNA, but here we are at the post-transcriptional level, and they will repress the expression of the translation of the messenger RNA or by just binding with the RNA and inhibiting the translation, or by forming a complex with other proteins, Argonaute proteins, that are nucleases that will break in several pieces the messenger RNA strain in those RNA-induced silencing complexes, as it's called. So that's the function within the cell. But those microRNAs, they can also leave the cell, and they do it, or they can do it by several ways. You can just have some budding or shedding of the membrane, and then they are captured in microvesicles. They can also be part if cells are going in apoptosis in apoptotic bodies, which of course contain also other constituents than just the microRNA. Or they can be assembled in also smaller membranous vesicles, which are called exosomes, which are assembled in a larger membrane vesicle that will fuse with the membrane and release the exosomes in the extracellular space. Or they can bind to adenine binding protein complexes, or they can bind to lipoproteins. But anyhow, they can bind to several or being transported in the extracellular space. It can be several body fluids and of course also the blood, and they can be transported to other cells, and they can then be internalized and exert their function also at the distance of the cell that has been producing the microRNA. So there's a very important physiology that we should keep in mind. What is also important is that by the fact that it's bound or encapsulated in several transporters, it is protected from the action of the abundant RNases in the blood. And that has as an important consequence that those microRNAs are very stable in extracellular fluids, and that's also a characteristic that makes them interesting as a potential biomarker, that stability in biological fluids, not only the blood but also in other compartments. And when it comes to function, to make it even a little bit more complex, this is a very elegant study that has recently been published, and I would strongly recommend you to read it. And what they have found is that one of the microRNAs, 99B, influences the FGF21 expression in the liver. But it's not microRNA that is produced within the liver. No, it's produced in the adipose tissue. So it's a signal that comes from the adipose tissue and influences the FGF21 expression in the liver. And it's not just every 99B in the blood that exerts this function. No, it's the exosomal and exclusively the exosomal microRNA that does it. It's not the protein-bound one. It's not the one in extracellular vesicles. It's the one in the exosomes. So really highlighting that it's very important to have an idea where those microRNAs are synthesized, how they are transported, and what is the tissue they finally will target for their function. So this complexity we should take into account. If we measure something in the blood, what do we really measure and what does it really do? I will just now briefly talk about two examples of those microRNAs, which are the most we know about and are relevant in the field. And the first one is 122, which is primarily expressed in hepatocytes and has a role in lipid metabolism. And what we know is that its liver expression is reduced in NASH patients. However, the plasma or the serum levels are increased in NASH patients. So this even adds more to the complexity of the issue because it's going in the opposite direction whether you look into the liver or in the serum. And if it's in the serum, then it's in a protein bind fraction and in extracellular vesicles, but protein fraction is not with the classical Argonaute 2 protein. So it even, as I said, add to the complexity of the issue because we really, if we want to interpret data on 122, we need exactly to know what we are measuring. Another one is 34A, which targets a lot of proteins in cell death and metabolic stress, and which is also related strongly to the PPAR mechanisms. And there we know that in FLD patients there are a few data, and all these data are always in very small cohorts. But we know that the expression in the liver is increased, and there the serum levels are also increased. So there you do not have the opposite, as was the case with 122. So the miR34A influences PPAR alpha and SIRT1 and is therefore implicated also in steatosis and steatohepatitis. And we also know that, and it's just by ways of an example here with the PPARs, but you can also look into other pathways. We do have more and more data on how these different microRNAs relate to a lot of pathways that are critical in the pathophysiology of NASH. Now, what can we do with that? And this is a work that we have been doing with GenFit that, as you know, also has its own biomarker program. And we looked in 2 cohorts, and I will explain tomorrow a little bit more in the abstract session about the details of the cohort. But the importance is that the golden cohort comes from the elafibranor phase 2 trial. And the second cohort, the obese cohort, comes from a screening program in patients with overweight and obesity that we prospectively assessed for the potential presence of NAFLD, and if there was an indication for it, then we proposed a liver biopsy. So these are 2 fairly large cohorts, about 250 patients each, but the way these cohorts have been built up is completely different. So you end also up with patients with quite different characteristics, metabolic and clinical characteristics, but also in terms of liver histology. And the first approach was a little bit hypothesis-driven, and we looked into these 3 microRNAs, and the first 2 ones you already recognize from what I just told you, and we looked with RT-qPCR and related it to histology. And one of the questions we tried to answer was the following. We wanted to identify patients that are currently the patients that we consider the most at risk at disease progression, which are also the patients that are eligible for pharmacological treatment. Patients with NASH, some degree of severity of NASH, so NAFLD activity score of at least 4, and some degree of fibrosis at least 2. And you recognize this, of course, as the classical inclusion criteria that we use also now for the phase 3 trials. And so we wanted to classify patients according to having this criterion or not, and we called it to be treated or not to be treated. So if we then look at those microRNAs, you see that for miR34A, there is a big difference between those 2 categories of patients, both in the golden cohort and in the obese cohort. Also for 122A, a little bit less, though, in golden, but clearly significant in obese, whereas for 200, we could see it in the golden, but we could not reproduce it in the obese cohort. Also, if you look more gradually at other histological features, here we look at the activity index, but the activity index here is the sum of the lobular inflammation and the ballooning according to the NASH CRN, so it's not the activity index of the SAF scoring system. Again, you see that there is a relation between the levels of those microRNAs in serum and the histological lesions, and again, you see between the cohorts that some things are reproducible and others are different. What we then did, and that's what I will present tomorrow, we did an unbiased approach with an RNA-seq technology to see if we could come up with other microRNAs than just these 3, which were based on hypotheses and what was already known in the literature. And then indeed we can identify, again, those so 34A and 122 come out, but there are also 9 other microRNAs that are overexpressed in both cohorts in the conditions. And here, as this is on patent filing by GenFit, I cannot reveal the exact nature of these microRNAs, but you see that we can identify other microRNAs that correlate with the to-be-treated condition and correlate with disease activity expressed by the NAFLD activity score and also with fibrosis. If we then look at each of these microRNAs separately and we look at the ROC of identifying those to be treated, you see here the figures for a single parameter that it's perhaps acceptable, and miR34A comes out as the strongest predictors in both, but also the other ones are interesting. But of course, as a standalone test, that will not be enough to do the job. So the question is, of course, can we do better if we combine? There is already some literature about this, and this is the most robust study to date that has been published. They started a little bit the other way around. They started with the discovery phase with an RNA-seq, but as you can see, in a limited number of patients, 20 NAFLD patients versus 20 healthy controls. So also the question here is a little bit different. It's the identification of NAFLD. It's not related to disease severity, although they had also data on disease severity and correlated also with that. But the main question was the identification of patients with NAFLD. And then based on what they discovered as relevant microRNAs, they tested the most relevant ones in a training and a validation set. And here you see that they have fairly large numbers in these two sets of patients. But again, it's NAFLD compared to healthy controls. And they could indeed identify some microRNAs, and 122 is coming back here. And if they then combine them in several panels, they come up with an ROC for the identification of NAFLD of 0.85 or 0.89, which is a lot better than, for example, ALT, which is also better than what the individual microRNAs do. So combining them really results in an improved diagnostic accuracy of these microRNAs, and it's also clearly better than the FIB4 score that they used here as a comparison. We started doing a little bit that kind of a combination also in the golden cohort, not in the obese cohort, but in the golden cohort. We started with 6 of the most relevant parameters, but you recognize, of course, some parameters that are also in the fibro test and in the ELF test. 2, which were less contributive, were finally left out, so it keeps us with a panel of 4 of these parameters. And as you can see here, this is performing rather well. But again, here the question is not NAFLD versus no NAFLD or just fibrosis versus no fibrosis. It's again that condition of to be treated, which is a combination of activity of the disease and fibrosis. This is, of course, again, diagnostic questions, different diagnostic questions, but diagnostic questions. Does it also have a relevance for the follow-up of the patients? Well, this is a results that Stephen Harrison has presented a few weeks ago at the EASL meeting in Amsterdam. And it's just an example because, of course, you can look at several of these data, but we looked at the activity index. Again, it's the sum of lobular inflammation and ballooning according to the NASH CRN. It's not the SAF activity score. But you see that in patients that have an increase in their activity, the score of this panel goes up. And for those who have a decrease of their disease activity, there's also a decrease in the score of the panel of 4 parameters that I just showed you. And that's true for the overall population, and the decrease is even more pronounced if we take just the more severe patients, namely the patients with a NAFLD activity score of 4 or more and a fibrosis score of 2 and more. So I think in conclusion, both DNA methylation and also microRNAs, we have some data. They correlate with several aspects of liver histologies. If we combine them in panels, then we increase their accuracy to answer the specific questions. So I think they have a value in all of kind of diagnostic questions we can put forward, probably also in follow-up and in monitoring of treatment. For some of these, we have biological plausibility. It's very complex. The physiology behind it is very complex, so we should really keep that in mind to really know what we are measuring, especially for the microRNAs. But that complexity and the fact that we know something about the action of those microRNAs and that we have some biological plausibility in some can perhaps help us also to address another question, which we briefly touched upon this morning, that's namely the likelihood of treatment response. We know that all our NASH patients are not responding equally to the treatments that we propose, and that reflects, of course, the heterogeneity of this population, but we have very little tools to make a distinction between different subtypes. But most probably, the pathophysiology of NASH will not be the same in all these patients, and in patient A, one of the mechanisms will probably be the most predominant one, and in patient B it will be another constellation of pathological pathways that is causing the disease. And if we could have up front an idea of what is the most important pathophysiological mechanism, then perhaps we can also have an idea of what is the best drug to use. Just a simple example here, to be a little bit innocent in the whole pipeline of drugs that's coming on. Take the PPAR gamma. We know that there is a link with miR-122. We know that there's a link with DNA methylation. So if we could identify in patients whether the PPAR gamma pathway is altered, yes or no, then probably if the answer is yes, then that patient will probably be a good candidate for a drug that targets the PPAR gamma pathway. And if that's not the case, then probably that patient is not a good candidate for such a drug. Of course, again, it's very complex because PPAR gamma in the stellate cell is not PPAR gamma in the hepatocyte. And PPAR gamma in the hepatocyte is not PPAR gamma in the adipose tissue. So it's for sure not as simple as that. But those biomarkers can probably help us to get a little bit further along the way. Still a long way to go, but anyhow, I think it's the way we have to explore this possibility. And with this, I thank you for your attention.